Alright, so this presentation is on medial epicondylitis. Let's start off with anatomy. Medial elbow. We're talking about the medial epicondyle, which is the common origin for wrist flexors and pronators. Alright, and medial epicondylitis is also known as golfer's elbow. Throughout this presentation, you'll hear me reference golfer's elbow more, mainly so you don't get confused with lateral epicondylitis, which you'll find out is also tennis elbow. So golfer's elbow is overuse of wrist flexors on the medial epicondyle of the humerus. This is caused to chronic stress during isotonic contractions, so we're talking concentric and eccentric contractions of wrist flexors and the pronator teres. To some degree, all of the wrist flexors are affected, but we're primarily seeing the pronator teres and the flexor carpi radialis that is affected. Medial epicondylitis, also known as golfer's elbow, accounts for 10 to 20% of all epicondylitis, meaning that this is the least common as opposed to lateral epicondylitis or tennis elbow. Mechanism of injury, like I said, overuse. Pitching, throwing, golfing, weightlifting, bowling, and racket sports such as tennis. This is primarily due to valgus forces on the elbow. So just because golfer's elbow is not called tennis elbow doesn't mean it can't happen in tennis. It very well can. It's just due to valgus forces. Signs and symptoms. Signs you might be able to observe: tenderness, tightness, weak grasp, dexterity, or mild swelling. But more commonly, you'll have to consult with the athlete because symptoms are more common, as the athlete may experience pain on the medial aspect of the forearm. Could be the entire forearm, could be just that medial epicondyle. Athlete might also complain of numbness, tingling, pain when shaking hands, or just simple wrist flexion. Predisposing factors, we've got training errors, improper biomechanics, equipment, lack of strength, endurance, flexibility, heavy physical work, excessive repetition, and I actually found some general risk factors. A lot of them actually didn't seem to be exercise related. Could have been just coincidence, could have been just nobody really knows. Differential diagnosis, I had a lot here. We've got cubital tunnel syndrome, ulnar medium neuropathy, ulnar neuritis, so a lot of it could be nerve related. Ulnar collateral ligament injury, like UCL sprains, fractures, loose bodies, probably caused by a fracture, strains, arthrofibrosis, triceps tendonitis, and synovitis. Believe it or not, a lot of these injuries can be differentially diagnosed. It's just a matter of knowing your anatomy. Like, for example, medial epicondylitis, as I've said, is on the medial epicondyle, as opposed to an ulnar collateral ligament sprain or UCL sprain. That is more joint line pain. So, I mean, like I said, you're just going to have to know your anatomy and know your landmarks in order to differentially diagnose. Special tests, I've got the medial epicondylitis test, also known as the golfer's elbow test. This is the same exact test, just different names. I actually found a good physio tutor video for this. I felt like that explained it very well.
Hi and welcome back to Physio Tutors. This test is designed to maximally stretch and thus provoke all the muscles that originate from the medial epicondyle and that attach distal to the wrist. To perform this test, have your patient in a standing position, fixate your patient's humerus, and palpate the medial epicondyle at the same time. Then passively supinate your patient's forearm, extend your patient's wrist, and extend the elbow fully. Okay. This test is positive if your patient complains about sudden pain at the medial epicondyle. Okay, this was our video on medial epicondylitis, also known as golfer's elbow, If you want to get to know 2 tests for lateral epicondylitis, also called tennis elbow, check out the Cousins test.
So, like I said, that is the golfer's elbow test. That was a very helpful video. I felt like that was very helpful to me, and obviously helpful enough to add this into this video. Alright, management and treatment of golfer's elbow. Management, most cases are non-surgical. If they are surgical, then typically what the surgeon will do, they will release the common flexor tendon, which is all of your wrist flexors, and they'll remove or debride that tissue that's causing the issue. And then cases that are non-surgical, typically what you should do is remove them from activities that really aggravate the athlete. You'll probably have to decrease the volume, intensity, and frequency of the exercise. NSAIDs and Tylenol will help. Icing after activity is helpful in reducing inflammation. Night splint might also be helpful if you feel necessary. And treatment, I mean, given the fact that golfer's elbow is less common than tennis elbow, golfer's elbow is actually more difficult to treat. You can refer to physical therapy. Strengthening exercises that you provide should focus more on eccentric activity of those wrist flexors. And then modalities would be helpful too, so e-stim, ultrasound, dry needling, and soft tissue manipulations. Mobilization, referral, brace. I mean, like I said, that night splint might be helpful if you feel necessary. You can always refer to a physician or a physical therapist as well. Prevention, proper stretching, proper mechanics, strengthen those wrist flexors. I mean, that's really the best way to prevent it. Also, to know your limits. So, it's very important for that athlete to know their limits. So, say if they're pitching, I mean, they need to know, how many pitches they can throw in a game. They shouldn't exceed that. They should keep reasonable limits. Mulligan techniques. I actually found a lot of videos on lateral epicondylitis, not necessarily medial epicondylitis, so those videos weren't very helpful. But you can actually use the Mulligan technique on golfer's elbow. Not so much the belt, more so manual manipulations. You can use a traction pad for just a better grip, and then you can obviously be able to tape the site as well. My peak out analysis was over 27 collegiate athletes, 10 of which were baseball players that were diagnosed with golfer's elbow. 17 were just healthy collegiate athletes in general. The intervention was that there were 3 different tape jobs that were applied to both these groups to prove if kinesio tape would improve the grip, strength, and pain. And kinesio tape was the test subject here, hoping that kinesio tape would relieve that pain and improve grip strength. And the comparison, we had the 3 tape jobs. One was no tape at all, another one was placebo tape, and kinesio tape obviously being the third. The outcome was that there was no trend, and kinesio tape did not show any significant changes in either wrist strength or pain. And unfortunately, there was no time frame given for this study. And here are my references. Hope you guys like this video. Any questions, comments, concerns, please go ahead and leave a comment.